Hi, I'm Christabel. I'm the lead respiratory pharmacist for Bart's Health for adults. I want to make this as useful as possible for primary care. I have been in primary care with some of the GP practice pharmacists. I've also have contact with a very good model that has worked, for example, in City Hackney, where the CCGF commissioned pharmacists to help do reviews across GP practices. I am not an expert in IMIS, so you can tell me whatever barriers that you guys have, because in my head I might think, is this a good idea? But actually in primary care, you can't pull things up easily. So it's a really good way to sort of have and open up a dialogue and conversation, because really I think it's very important for us in secondary care to engage really well with the GPs and the practice-based professionals who are actually helping prevent admissions to our hospitals. So today I'm really trying to make everyone aware that we have got an adult asthma guideline that was published last year, or signed off last year, but it was actually sort of drafted and worked on the year before the NICE 2018 guidelines were actually launched. So we will be looking to sort of update things as we go along, especially with the fact that COPD has just launched their 2018 guidelines. The GOLD 2019 guidelines look dramatically different as well, and there's obviously the asthma overlap grey area that's been addressed in the COPD guidelines. Hence, our asthma guidelines in the coming year will be something we will be looking into to update things. So I don't know whether you are already aware. Anybody's aware of the Trust Bart's guidelines? If not, I'm going to show you what it looks like and where it stems from and how it might differ from your NICE guidelines, and what the differences are highlighted just in one slide. The other thing we want to touch on is actually what does good look like to all of you in your practices, because we do have access to data on right care. Everybody has access to how we're performing in terms of respiratory healthcare, and actually looking at, I don't want to just talk about targets, but obviously the targets were generated from clinical care sort of indicators that actually we know will lead to exacerbations or will lead to admissions. And if you have access, or if you've got a respiratory lead within your practice, it's really good and informative just having a look at your Tower Hamlets data to understand how your practice is performing in terms of doing annual reviews. So I can tell you that in 2016 and 17, only about 70% of asthma adult patients had an annual review conducted for them. And this is not very helpful for a GP who has 10 minutes and a patient coming in, and you have to review everything. You do not have 10 minutes to try to do every single questionnaire that you could maybe do potentially properly in an annual review if you book them in for a 20-minute session. So what does good look like, I think, is very important that every person, every practice needs to think about as a team. How do we want to achieve what good looks like for them? And that is linking in with the asthma review and whether we're using action plans for our patients. And last of all, I'd like to leave it to questions, which I've really taken one of them about pheno testing and diagnosis, and we'll touch about that in a bit. So, in terms of talking about the guideline, on the table I have laid out two sheets, one that looks like this, which is a stepwise, well, I call it stepwise, it's a really old term, but really now asthma guidelines don't really talk about step or ladder care. So a very simple table about what you're doing in escalation of asthma care. And the second sheet is a simple pictorial format of what the different asthma licensed products are available in terms of the inhalers. So I'll talk a bit about the underlying principle, the application of it, and just the differences of the guideline. When we developed the guideline, the main thing was that we are thinking that somebody needs to be able to use the inhaler, and that means inhaler technique, and that means adherence. So developing the guidelines, we're going to start off and thinking about the patient. What can that patient use? Because the least clinically effective and least cost-effective treatment is actually the one that the patient cannot and will not take. And I think that's the most important take-home message that everybody needs to know. And that is the basis of how you will form your consultations, your annual reviews. And moving on, even with the COPD guidelines that I'm currently drafting in conjunction with CCGs and consultants, we're going to start off with the very first thing is we need to establish what the patient can take and will take. So the rationale and the stepwise version is literally doing an inhaler technique check, checking their inspiratory effort, checking their dexterity, and then understanding what their barriers are. Is it because the lifestyle doesn't enable them to take a BD dosing versus a once daily dosing? Is it that they have got arthritis in their hands, they can't actually use an MDI properly? What is that barrier to dexterity the patient has, or a personal belief of, I can't cope in my day, do I work long shifts? Actually, a once daily dosing is better. So thinking about what would help that patient adhere to the treatment before you make a decision on the actual medication molecule that you're going to then use the guide to then decide which one it is. So if you look at the guide itself, we have split it into patients that can use your sort of MDI devices versus your dry powder devices on this side. So your decision tree right from the start is all about your patient in front of you. What's the inspiratory effort? Can anyone tell me how we check inspiratory effort?
INS machine.
Pardon?
The INS machine or Indel check.
Indel check, very good. Does every practice have an Indel check?
I don't know.
Yes? Yes? If not, do invest in one, because you can just get the different mouthpieces and they can be reused and shared in clinic. And also there are obviously things like your turbo halo whistles. So for example, we can get turbo halo whistles, which are the red disposable ones that marketed for Symbicort, for example, any turbo halo device. If they can whistle that, we know the inspiratory effort to use a turbo halo is much higher than some of the other devices available, for example, your MDI. If they cannot whistle that, you know you need an MDI version. So then you know that your decision tree of going down in terms of what drug you're going to choose would be in this sort of left-hand column of the step, depending on how your patient presents to you. So I think that's the main thing. I'm not going to talk you through the different individual devices or the drug unless anyone wants me to go through that, because it's quite self-explanatory. Any questions?
Can I just give a promo for a website called Right Breathe?
Exactly.
You might have seen. It's
Yes.
fantastic by NHS
Yep.
London. It's called Right Breathe, and you click on there. It's asthma, COPD, and different licenses. So you can, for example, pick COPD,
Exactly.
LAMA or LAMA-LABA combination.
Yes.
With different brands.
So that's for especially,
And it gives you a picture of
I guess if you think about your asthma cohort of patients,
Right Breathe.
Right Breathe. So Right Breathe is an app that you can download. You can show it on your computer screen when your patients are there as well. And if you type in any of the drug, you're not sure of any of the device, you click on it, and there's also a YouTube video at the end, at the bottom, which you can play, or you can ask your patients to download. A lot of patients, asthma cohort, are younger patients anyway, so a lot of them will have got sort of smart devices which you can actually encourage them to use Right Breathe. Thank you for reminding me about that. So in terms of the escalation process, I mean, the thing is, by the time they come and see you in adults, I don't really know the kind of patients you might see on a day-to-day basis. I think they vary quite a lot. So for example, yesterday I saw a patient where she was pregnant 14 weeks and she has been really breathless on exertion, and she normally trains for a marathon. She's never had a formal diagnosis or anything like that. She had a very, very busy lifestyle. And the previous pharmacist that had seen this patient would have already given her a starting clanomodulite, because she did not actually, she couldn't do some sort of like peak flow readings due to sort of time basis. They must have had a discussion. So looking at the consultation, it looked like they didn't do a peak flow diary at that stage, but they did do a peak flow at that stage in the GP surgery, but there was no diary kept. And basically, she came back a few weeks later, having used her clanomodulite and her peak flow has increased significantly. So we're not going to put this poor lady through any other formal sort of like long-term testing because it's not practical, I guess, and you've got that time frame. So I guess you have to be practical in adapting how you want to diagnose asthma. The fact the patient has significantly improved in her symptoms, you would tell her to continue doing what you want to do and do an asthma action plan at that stage, which is what we did in clinic yesterday for her. We also saw another gentleman yesterday where he was actually on Pulmicort, and when we reviewed him, I had a quick look at his GP records, and he actually requested maybe about 12 SARBAs in the last 6 months or so, and he probably only requested his Pulmicort twice. So again, and he's a well patient, just by speaking to him, no exacerbations. His ATC score was good, showed that he had good asthma control. And actually, what we actually discussed with him is that he was very anxious. I think he was almost dependent on his SARBA, and he was using it more frequently. So actually, excuse me, when I say his ATC score was good, it could be better controlled. I wouldn't say that it's completely well controlled when he scored on everything, but in a sense that he had no exacerbations. So we actually thought he was quite a good candidate to switch to what you call MUT therapy, and we actually just got him to do that, for him to keep one of the SARBAs during the transition phase, and then actually at some point we want him to stop cutting down using that sort of like frequent SARBA usage, if you see what I mean, because we explained to him how MUT therapy would work for him, and we will see him again actually in about a month's time to see how he got on with it. So it's about sort of like with your different patient presentations, understanding ACT scores and sort of understanding your sort of your three RCP questions would be quite important in sort of enabling you to make a decision tree down using the guideline. And the last slide on the guidelines is just to highlight what the differences are. Basically, in NICE guidelines, they've actually recommended the use of Montelukast a lot earlier before stepping up to the ICS-LABA. In our BARTS guidelines, we have not done that. Firstly, because we've obviously done our guidelines before NICE came out. But secondly, NICE actually did Montelukast as an earlier recommendation more from an economic evaluation point of view. We still believe that stepping up the ICS actually works much better for our patients. So in our clinics, that's what we're actually still doing, and we're still using these guidelines and not using Montelukast much earlier in our adult patients. The consideration of MUT therapy, there's not a lot of evidence about where MUT therapy really places, but there will be new sort of evidence coming out with new inhalers going to be launched sometime this year about using MUT therapy much earlier. So if you look at our BARTS guidelines, we probably do start patients who are suitable for MUT much earlier on. So as I said, it's about patients' perceptions, understanding of the inhaler, the device, before we decide which patients can use MUT therapy. So watch the space about MUT therapy, because I think there will be a launch of Symbicort coming out with new evidence of using MUT therapy much earlier. So I think I'm sure it will come up sometime this year. Okay, so watch the space. And in terms of step down for asthma, I know that a lot of places do what you call like a 3-month review for step down, but our clinicians believe that because a lot of the asthma triggers can be seasonal, so what happens is if you do step down within 3 months, you might miss the next trigger season. And that's why we're actually asking for a 1-year sort of review stability before we step it down. So that's the three-ish differences. And I know I've touched a bit on this earlier already through what I was talking about, but what does good look like for all of you? Anyone? Ideally, what does good look like, having gone through your IMIS templates for asthma review? What do you think is the most important? Or rather, what's actually always missing? If somebody has, for example, if you had to see an asthma patient and you had a quick look at their action plan, their asthma review, what's always missing? What are the barriers to filling up what's in your IMIS template for asthma review? Because it should not just be a template for a tick box. What we want to do is make sure that it's actually useful for your care of the patients.
Inhaler technique.
Inhaler technique. What are the barriers for doing an inhaler technique check? Pardon?
Not having the medication there, so you can actually.
So patients not bringing in. So are patients reminded before their annual review appointments to bring them in? Is there a system to do that?
My receptionist has it,
Yeah?
but then they forget. Still don't bring it in.
Fine, okay. And what do you do in those cases?
If you've got a dummy one, we use that. But, you just ask them to show it to you.
Yes. So another way of assessing is whether you are, I normally will ask the patient to say, can you teach me how to use your inhaler? And usually the way they sort of demonstrate could sort of give you a gauge as to whether it's fairly good or actually it's really poor. And I think that's a really good thing to sort of not miss just because they don't bring an inhaler in. And would it help if you guys have lots of devices, placebo devices? Yeah. Okay, so I am hoping that I can sort of get bulk sort of placebo orders. I don't think GPs can. Hamlets doesn't allow like drug companies to drop off placebos, am I right to say that? But I'm sure they would allow the delivery of placebos. Okay, so what we'll do is that I'm trying to get a list from the Hamlet CCG and try to work out whether we can do bulk orders so that they can work out a distribution thing among the GPs, and I think that's quite important so that you've got an ongoing supply of things. I'm quite sure the RCP 3 questions, your ACT is as part of your IMIS form, am I right? Yes, no?
Yeah.
Just shout it out?
Yeah.
Yes? Okay. How long do you think it takes to fill that in?
The ACT is longer, isn't it?
First of all, you have to find the website and load the questions.
Okay. Is it not inbuilt with IMIS at the moment?
Not all of them, are they?
ACT bit was
Oh, is it?
the second
Okay.
part of the template.
Okay.
But it's a bit longer, isn't it? It takes time.
It's 5 questions.
Yeah.
Yeah, but the thing is, it does sort of help you open and structure your sort of consultation, and that's why I put it at the top, because I guess the first thing when your patient comes to see you, you want to know what they're in for, so that's why I put diagnosis, check and coding right at the top, because a lot of times you might see asthma diagnosed 1999, COPD diagnosed 2016, and actually establishing what you want to go with is probably very important at that stage. So even before going down the whole review, I think that check's really important. And if you see a huge discrepancy in like dates and you're not quite sure, and by the time they come to see you, it's like, oh my God, he's a smoker, he's got all these other clinical features, they say he's more COPD or asthma, then you need to start thinking about your MRC score, your CAT score during a review to make sure that you make the best use of your time. And I guess the thing is, asking about triggers is really important because that forms part of how you want to write your action plan. So what I'm trying to say is, if you actually ask the bits in the right order, and hopefully it does match up your IMIS templates, then by the time you come right to the end of the consultation, your action plan is more or less formalized, and all you're really doing is printing off an action plan, and you're doing a summary to recap and close your consultation off, repeating the bits that you've actually elicited from the patient right from the start of your consultation. Smoking. How often do we ask that question? All the time? How happy are patients to take up smoking cessation referrals? Do you offer it in your own GP practice? Have they seen NRT before? Have they seen how it looks like? Do they know what it looks like? Yeah?
Well, we used to do it, but then public health took it over, so we're not doing it anymore.
Yeah? But I think it's still quite useful to have a tool where you have a little box just to say, if they're not sure what NRT is, what does a spray mean? Patients who never used it, or they're only used to patches because, the patch is something they're so familiar with. But, an inhalator, showing them actually, it mimics like a cigarette, it's like a hand-to-mouth habit. Do you think it would be something you might want to try? What does a quick mist look like? Having a little box you pull out, just like how your placebos look like, probably give them a like, oh, it's not that scary, it's not that bad. It doesn't look that uncool if they think cigarettes are cool. It's having that sort of pack ready in your clinic that it's easy to sort of pull out and have that conversation. Also because if you've got the pack there, it triggers you to ask them if they smell of it. Because a lot of them say, I don't smoke, but they actually smell of cigarettes. And then after that, your whole consultation room smells of cigarette. And then I guess asking them, so what are you using currently? Tell me, you've got a brown inhaler, or is it a pink inhaler you've got, or a blue one? So tell me, how do you use them? Because by them actually telling you the doses, how they use them, how often, their understanding, you're already checking their understanding, their adherence, and then asking them to show you how you use it, all in that one bit. Because you could probably easily pull up how often they have also requested their prescriptions and see whether that matches up while they're telling you that. Yeah? And I guess I'm sure in your IMIS template, they will ask you things like number of exacerbations, which is we're talking about times where they've actually had used the steroids as well. A&E attendances, any admissions. So any A&E attendances might be different because they might just present to A&E but get discharged straight away. They might or might not get a discharge letter. I don't know how tied up the whole system is, but it's just worth asking that. And also because they might not call it an admission, or they might call it an admission but actually didn't get admitted. So it's just worth clarifying. Now, peak flow reading. Do all your patients have a peak flow meter at home? Is there a reason why? Because then how do we tie in to explain to them about the action plan? Because we should prescribe them a peak flow meter. And that goes the same for secondary care. So, if they don't have one, they have to go home with one, unless the patient says they've got one. So it's just worth thinking, prescribing peak flow meters for patients, prescribing aero chambers separately on your FP10s as well for them. And intervention needed, obviously, after you sort of gone through this whole consultation. It gives you an idea as to, is it something I need to do here? Do I have to change therapy here? What do I have to do? What referrals do I have to do at this stage? Yeah? And then I guess the last bit, as I said, is about the action plan. So the action plan, we use the Asthma UK action plan. How many of you fill in action plans for your patients all the time? Do you think everyone's confident in filling an action plan? I think the first barrier is about that first step. Once you filled one in with one patient, you realize that it's actually not that difficult. So the barrier is that you just need to try and start. You need to know what to say to them. I'm not saying that every patient obviously is suitable for a peak flow meter, because if you get a very anxious patient and try to treat numbers, you probably want to avoid them doing something like that, because you don't want a patient calling you every day telling you about their peak flow reading. So you have your discretion about which are your suitable patients, and more often than not, most patients will benefit from having a peak flow meter. Literally, your green bit is very self-explanatory about what the current maintenance, if you're feeling well in yourself, what's your everyday therapy. When you're feeling worse, literally explaining to them what is different from their norm, making sure they recognize what is different from their norm, making sure they recognize what their triggers are, it's really important. And if, let's say, they were on Clanil, 100, one puff twice a day, what are you going to be asking them to do? 2 puffs twice a day, 4 puffs twice a day? You need to write that down for the patient. And we're talking about, if your peak flow reading is less than 80% of the best, so not just writing a number down. So in the clinic itself, making sure you do a peak flow reading in the clinic, because if they seem that they're well, and then obviously tell them that, okay, this is your peak flow reading today, but your predicted best should be this. Are you close enough to it in the first place? Yes? Making sure that that number's written down in the green bit so they know, and calculate it out and write it in a box for them, so that if it's less than 80% and the number is below that figure, they know what their action should be. Should they be starting oral steroids? And if they start oral steroids, they need to contact the GP to let GP know that they have actually started it. And then, of course, if their peak flow is less than 60% of the best, again, write 60% there, less than 60%, because if their best changes, then you can calculate it accordingly, yes? And then we'll say, best to start on oral steroids, and then seek medical advice. And then what do you tell them to do if they've got asthma attack? Again, it's quite good to make sure that they've got aero chambers with their sabers, because if they're having an asthma attack, they're not going to be able to do deep, quick breaths. So you have to go through that technique in clinic to say, what are you going to do? So you're going to attach your aero chamber to your MDI. You're doing one path. You're doing like tidal breaths and actually demonstrating what a tidal breath will look like. Slow, steady breathing. Because also you get very anxious when you're breathless, so that probably would help the patient. So that kind of information should tie up in your action plan. So I know you asked about pheno. I don't really think realistically every GP practice will have a pheno machine, but I think at some point we're thinking about hubs where maybe we could send for those pheno testing. And if you think about pheno testing, the result is not exactly diagnostic anyway. So you're going to still be using a clinical picture to match it up with a variety of objective things like spirometry. And if they do have normal spirometry, what do? Think about, can we look at variability using peak flow readings? Are they able to keep a diary? Or would you want to give this person, like maybe, for example, a steroid inhaler, try it out and see whether there's a difference in their peak flow, see whether there's a difference later on after you've given them, an intervention. So there are different ways, and of course, if your results are still very sort of grey, maybe your pheno would help, and that's probably when you want to refer to a hub where they want to actually do a pheno sort of result. Again, NICE talks about, more than 40 being sort of like helpful in being diagnostic, but when I look at pheno results in secondary care, we're using in a severe asthma patient groups as well, and it sort of helps me look at things like have they been using and being adherent to their inhalers, because if they've been on treatment, on steroid courses and all, that does obviously affect your pheno level, because that is an indicator of airway inflammation, nitric oxide. So it's not really diagnostic, but it's something that could help marry up with a full picture. But at this stage, I'm not sure that every GP will fund their own machine. I personally don't know.
It's about £2,000 for a machine, and then you've got the consumables after that. And I think that's the significant difference. But I think what's interesting, and that's why I find that this is hopeless because you can't actually read it, but the Red Whale is a kind of amalgamation of both of the British Thoracic Society and SIGN guidance, and re-emphasises that it's a clinical decision, asthma, and that whilst if you have uncertainty, there might be a place for it, that they're not in a rush to encourage people to invest. And certainly in the North East London Asthma Working Group for Children, we've decided not to look any further at pheno testing because it doesn't seem like a wise investment for the benefit.
Yeah.